going to discuss about very interesting cases regarding to rickets, which is a common presentation. And we know most cases of rickets are related to vitamin D deficiency, but there are substantial numbers which are related to resistance to vitamin D. And these cases are associated with abnormalities in either the renal handling of the phosphorus, the acid, or the calcium, or there is some problem in terms of vitamin D activation or action. Today, we're going to discuss about 4 very interesting, diverse types of cases, which will focus upon different etiologies of refractory. Boy who presented with rickets and was given a case of vitamin D dose was given. The parents were really concerned about bone pain and a high level of alkaline phosphatase, which was found on follow-up. And calcium levels were normal, and the patient was labeled quote unquote as refractory rickets. Now, as well, we'll discuss about that. We need to understand that once you treat, there are different changes which may happen, which can cause bone pain, and the ALP is a marker of bone formation, and the levels may go up. So this is not really a case of refractory rickets, because once you label refractory rickets, you have to do many complicated investigations like blood gas, PTH, vitamin D, calcitriol, which is not going to help out and will cause more confusion or problem. So this was clearly a simple case in which if we had looked for the line of healing, it was present. So this was a classical case in which we were messing up with a simple case, making it more complicated in that regard. So this was a normal response. On the contrary, we have this 14-year-old boy who presented with rickets with very early onset from around 3 to 4 years. And we can see significant lower limb abnormalities, has received huge amounts of vitamin D. There was no response as far as the radiological picture was concerned. There was no line of healing. And despite that, vitamin D was continuously given, which had unfortunately resulted in nephrocalcinosis. Now, this is a prototype case of refractory rickets in which it was found to have hypophosphatemic rickets. So we have got the 2 extreme scenarios, one where we are unnecessarily messing up a case, and here what we are messing up a case. So this is the scenario which is there from that regards. So rickets can either be missed, and this can have significant consequences. It is a common disorder. 90-95% are nutritional, but we need to identify individuals who are unlikely to respond to vitamin D because they require comprehensive evaluation and assessment from that regards. All of you can go and have a look at our website, Learning.Grow Society, which is a learning portal providing courses about pediatric endocrinology, including fellowship and diploma programs. We do run regular activities in the form of journal clubs, postgraduate lecture series, and grand rounds like this, which provide insights using case-based approaches. We have got publications in pediatric endocrinology, which are available both online as well as in a hard copy. Application also helps in terms of day-to-day management. So today, our agenda would be to focus a bit about rickets to begin with. Then we'll talk about hypophosphatemic rickets, a very interesting case by Dr. Vibha. Then Dr. Yeting will be talking about the case of VDDR. Dr. Musa will also talk about a similar case which we encountered. So just to contrast the 2 approaches there. Then we have a case of proximal RTA by Dr. Manoj and distal RTA via Dr. Dhwani. And this will really complete the entire picture of the 4 major causes of refractory rickets. Now, when we talk about rickets, we are talking about 2 things, calcium and phosphorus. Now, both of them are important for bone formation, but the most important is actually phosphorus. And it's the phosphorus deficiency which is actually responsible for rickets, because phosphorus causes a chondrocyte apoptosis. If the phosphorus levels are low, you will not have apoptosis, and therefore the growth plate will grow more and you will develop rickets. So rickets is essentially a problem of calcium and phosphorus. And we know that the major regulator of serum calcium is actually vitamin D axis. So vitamin D, which is produced either under the exposure of sun or 5% from the plant sources, is then activated by the liver to 25-hydroxyvitamin D, which is further activated via 1-alpha hydroxylase into calcitriol. And this calcitriol then causes the effect which happens in terms of increasing absorption of calcium from 25% to 40%. And if you are deficient in either vitamin D, in 25-hydroxylase, 1,25-dihydroxylase, or if you have a problem in vitamin D receptor, you will develop a refractory rickets. There is also an inactivating pathway of 24-hydroxylase, which inactivates this to inactive form, and which basically results in decreased action from that perspective. Phosphorus levels in the body are largely determined by how much is the urine excretion of phosphorus. So major disorders of phosphopenic forms are associated with low level of serum phosphorus and a high level of urinary phosphorus, which is reflected via a low level of tubular maximum of GFR, which is TMP GFR. Now, phosphopenic rickets needs to be differentiated from the calciopenic rickets, which is basically a calcium and vitamin D problem. But remember, all forms of rickets are ultimately phosphopenic, because if you have calcium deficiency, your parathyroid hormone will go up. And as soon as your parathyroid hormone goes up, you will lose phosphorus in the urine. So everybody with rickets should have a low phosphorus, and that's an important distinguishing point. If your phosphorus is high with rickets, there are only two conditions you are thinking of: renal failure or a pseudo hypoparathyroidism. So phosphorus deficiency is common, but if it is because of secondary hyperparathyroidism, then you will have the calciopenic rickets. While if it's because of a primary tubular pathology, your PTH will not be high, you will basically have a phosphopenic form of rickets. So phosphopenic rickets could be part of a generalized tubular dysfunction like Fanconi syndrome, or a specific problem in which the phosphorus losing substances are more in the body, which is the phosphatonins, typically FGF23, which is acting via the hypophosphatemic rickets. In this condition, you will not only have phosphorus deficiency, but also the increase in calcitriol does not happen. Anybody whose phosphorus goes down should have a high calcitriol. So here the FGF23 not only causes phosphorus excretion, it also causes inhibition of 1-alpha hydroxylase. So these individuals, you need to treat with both calcitriol as well as phosphorus in that regards. There is one exception in which there is a problem of the sodium phosphate pathway, wherein you will have hypophosphatemia with high calcitriol. And this is going to cause you hypercalciuria. So if you have hypophosphatemic rickets, always measure urinary calcium before you start calcitriol, because you may have that NP2 variant which may cause nephrocalcinosis will develop quickly. So this form of rickets typically presents late, predominantly with lower limb abnormalities, and otherwise the child looks normal. He is not sick from that perspective. While the calciopenic rickets can start right from decreased exposure to sunlight, decreased calcium intake, a chronic liver disease with malabsorption, use of anti-epileptic drugs which increase inactivation of vitamin D, abnormalities in the kidney functions like chronic kidney disease, decreased production of calcitriol, which is vitamin D dependent rickets, and you will have an early onset rickets in a sick child who develops tetany and hyperparathyroidism. So if you want to distinguish between calciopenic and phosphopenic rickets, having hypocalcemia, having hyperparathyroidism excludes a primary phosphopenic pathology. This is an important thing to remember. So PTH becomes the second very important investigation when we talk about evaluation of rickets. There is also a third group of disorders, which is because of tubular abnormalities, largely because of metabolic acidosis. Now, these disorders are not really affecting the vitamin D to a great extent. The acidosis itself is causing abnormalities in the bone. So these disorders will present to us with failure to thrive, with polyuria, with nephrocalcinosis, so distal and proximal RTA. Now remember, proximal RTA presents earlier with much lower level of phosphorus. You will have urinary glucose or urinary amino acid uria. The severity of acidosis will be milder in proximal RTA. So you may miss actually these cases. Distal RTA presents a bit later, but the severity of acidosis is much more. You may have hypokalemia. You will develop nephrocalcinosis. And if you don't treat early, you will develop pathological fractures, very, very fragile bone. So later onset, 6 to 10 years of age, significant failure to thrive, hypokalemia, neck flop, fractures, think of a distal RTA. First 2 to 3 years of life, very low phosphorus levels, urinary glucosuria, start thinking of a proximal RTA from that perspective. So now, based upon that perspective, we can classify rickets into deficiency, which is both calcium and vitamin D, in which you can look at the therapeutic response to rickets. Then it may be refractory, which can be calciopenic because of VDDR 1 and 2, renal failure and malabsorption, which is early onset hyperparathyroidism and hypocalcemia. You can have acidosis because of proximal or distal RTA with polyuria, failure to thrive, and if it's distal RTA, you will develop nephrocalcinosis. And finally, you will have the phosphopenic form in which you have hypophosphatemic rickets, Fanconi's disorder or malabsorption associated with late onset lower limb abnormalities with normal calcium in PTH. So if you now remember just two things, phosphorus, calcium, PTH. These three will classify all your forms of rickets and we'll use it for further evaluation. Now the big question is, when you're facing a child with rickets, is it really rickets? If it's rickets, is it refractory rickets or not? And then finally, what is the cause? So rickets, of course, is a radiological diagnosis, but clinical parameters can give you a clue. So you can have a genu valgum, genu varum, and windswept deformity. Now remember, genu varum may actually be a normal phenomena in infants. So if you have a windswept deformity or a genu valgum, that is much more significant. But remember, 1 to 2 years, you can have some form of bony which may happen. And of course, we know about the cupping, fraying, and splaying. All those are characteristic. The next question is it refractory or not? The answer, of course, is that you should give a therapeutic trial of vitamin D and wait for that. So these are the guidelines by the Indian Academy of Pediatrics, which are similar to the consensus statement by the global team. They talk about 60,000 international units fortnightly for 5 doses beyond 12 months or 3,000 international units daily for 12 weeks. So you have to wait for 3 months to get the response, and then you will decide whether it's refractory or not in that regards. Now remember, when you give vitamin D, you will cause increased absorption of calcium and phosphorus. And this calcium and phosphorus will go into the bone to cause deposition and mineralization of the bone. Now, in this scenario, if you are deficient in calcium and you are not giving calcium, you may develop what is known as hungry bone syndrome, or there may be bone pain. So bone pain may be a normal phenomena which may happen. So always give calcium with vitamin D. So this is common. The second thing to remember is that when you are actually giving calcium and phosphorus, the overall turnover of bone will become more. Your osteoblast will act more, your osteoclast will act more, and osteoblast will produce alkaline phosphatase. So alkaline phosphatase levels may rise during the initial phase of treatment. This is basically a marker of a response. It's not a marker of refractory rickets. You have to be cautious about in that regards, and rise in ALP may happen. So the gold standard for response is the line of healing. That is what you need to look at in that regards. So refractory rickets, you need to show that there is rickets, both clinical as well as radiological, and you have given adequate calcium and vitamin D for 12 weeks. There is no line of healing. This is refractory rickets to you. But remember, in certain scenarios, there may be confusion which may cause diagnosis of refractory rickets, particularly, as I said, high levels of alkaline phosphatase, hypocalcemia, and bone pain after treatment, which does not mean that you have rickets. It basically means that this is a normal nutritional rickets which is responding. Wait and watch for more time. Other things which may cause rickets are like skeletal dysplasia, pseudo-hypoparathyroidism, or fluorosis, which may look like rickets. And of course, because they are not rickets, they will not respond to vitamin D, and you may label them as a significant case of a pathophysiological cause. One condition important is hypophosphatasia, and this is characterized via an absolutely low level of alkaline phosphatase. So I've talked about calcium, phosphorus, PTH. The fourth player is alkaline phosphatase. So if your alkaline phosphatase is high, that is a normal response. If ALP is normal, you may be dealing with RTA, which is a low bone turnover. If it's very low, think of hypophosphatasia. So alkaline phosphatase is very important. But many times, first time you are seeing the child, you may think, okay, this is something important. I want to exclude a refractory rickets. So if there is polyuria, fractures, normal nutritional rickets does not cause fractures. So if there is a fracture in a child, significant failure to thrive, you think of refractory rickets. So we've now known that this child has a refractory rickets. a good dose of vitamin D and calcium was given, but still he is not responding. So what's the cause? So from here, we will need to understand what are the causes. So this is from my publication long time ago. And what we see, the four major causes was distal RTA, proximal RTA, VDDR, and hypophosphatemic rickets. And we'll be presenting all four of them in the discussion today. If you go by the Western textbooks, they talk about distal RTA not being a cause of rickets. The reason is if you pick them up at an early stage, they will not develop rickets. But if you delay the diagnosis, like often happens in that regards, you would have a delayed diagnosis and that will cause a significant problem from that perspective. So you need to be cautious about in that perspective to evaluate and assess from that regards. So always take a history of if there is any tetany or any features like that, you can think of a calciopenic rickets. If there is polyuria, it indicates renal tubular acidosis. If there is a primary lower limb abnormality, this is more like a phosphopenic rickets. On examination, if there is anemia, this could be celiac disease or a chronic kidney disease. If there is alopecia, particularly alopecia totalis, this could be a variant of vitamin D dependent rickets type 2, particularly the ligand binding domain causes this. Look for the eyes for the crystals, and this could be an indicator of cystinosis. Hemangiomas, and hemangiomas are important because they may secrete FGF23, and if you remove those tumors, your rickets will improve. That will be an important thing. And of course, if there is mottling of teeth, think of fluorosis as a possibility. Now, if you look at clinical parameter that we have mentioned here, the most important, of course, is calcium. Calcium will, of course, be very low in VDDR. Phosphorus will be low in everybody. ALP will be higher in most, but not that high in distal RTA. So basic parameters will help you out in that regards. And nephrocalcinosis, of course, will give you a direct picture towards the diagnosis of a distal RTA. Important to remember is that amino acid urea, which is a marker of a proximal tubular dysfunction, may also happen in distal RTA because of secondary hyperparathyroidism. So this is the paper that we published there subsequently. So if we now look at the primary causes, I've mentioned those four causes along with renal failure and PHP, so 6 causes. The most important is phosphorus. If your phosphorus is high, it's renal failure or pseudo-hypoparathyroidism. Then calcium, if it is low, it excludes hypophosphatemic rickets. A normal calcium and a normal PTH suggests the possibility of a hypophosphatemic rickets. So generally, everybody who has rickets should have a low phosphorus and a high PTH. If your PTH is normal and phosphorus is low, think of a hypophosphatemic rickets. And of course, urinary calcium, if it's high, it's more like a renal tubular acidosis, and acidosis will also give you a picture. So most important thing is phosphorus, second is PTH, and then of course, ALP and urinary calcium will give you a clue. So back around 17, 18 years ago, we gave an algorithm at that time based upon our results. Results are pretty similar. So this is our current algorithm. So first, of course, is to look for response of vitamin D, maybe wait up to a period of approximately 3 months. If there is response, it's a deficiency rickets. If there is no response, look at phosphorus. If phosphorus is low, you can have RTA, you can have VDDR, and you can have hypophosphatemic rickets. So look for blood gas. If it shows acidosis, that is renal tubular acidosis, you classify using urinary pH, urinary carbon dioxide to blood carbon dioxide difference. You can use this fraction excision of bicarb into proximal or distal RTA. We'll talk about this a bit later. If the blood gas is normal and your calcium and PTH is also normal, this is hypophosphatemic rickets. While if you have hypocalcemia, you have VDDR, which you can classify using calcitriol level. Low level suggests VDDR1 and high level suggests VDDR2. Remember, calcitriol should be done only when needed. If you do calcitriol level in vitamin E deficiency, the level may be low, normal, or even high. So it's not a very, very good marker because it is affected by PTH. It's substrate independence. These are the all problems which happens with calcitriol. Now, on the other hand, if your phosphorus is high, only 2 diagnoses are there. If creatinine is high, this is renal failure. If creatinine is normal, this is pseudo-hypoparathyroidism. So, of course, look at response to vitamin D, look at phosphorus, low phosphorus, look at blood gas. If blood gas is normal, calcium and PTH, If phosphorus is high, look at creatinine. So this is how you establish the diagnosis. We have specific approach pathways which are dedicated to rickets in our application. You can use them to identify the cause of refractory rickets.
Ms. B, who presented to us at 12 years of age with complaints of poor weight and height gain, recurrent fractures and polyuria from an early childhood, about 6 to 8 years of age. With this, the mother gave complaint of anorexia, nausea, intermittent nausea, and like a poor health in general. For these complaints, they had shown to multiple doctors, received on and off treatment for a number of years before they presented to us. Development-wise, she was otherwise normal, had mild gross motor delay, which had improved with age. Antenatal and perinatal history was insignificant. There was no history of similar complaints in the family and no sibling deaths. She was immunized for age. The parents were told that she had rickets and had received vitamin D calcium supplements for on and off for over 1 to 2 years with no significant improvement as per the parents. At presentation to us at 12 years of age, she was significantly stunted, underweight, and wasted. She had mild tachypnea, tachycardia with an acidotic pattern of breathing. Head-to-toe examination showed no obvious dysmorphism, no obvious hearing and vision abnormalities. However, we could appreciate widened wrist and genu valgus.
So if now look at a later onset of presentation with such severe failure of the time,
yes.
If we go one by one, can it be BDTR?
No, we would expect a younger age of presentation.
And with hypocalcemia, could it be hypophosphatemia rickets?
Yes, but again, it's a girl child. We do not expect it to be so severe, and we would have.
Height is very, very short,
yes.
And you have got significant bone pathology.
Yes.
Now, proximal versus distal.
Proximal versus distal. So yes, again, as we had seen in the previous one, proximal would present earlier. They might have cataracts, they might have other associated abnormalities. So
if we just look at all these cases that we discussed today, the first case classically had a later onset presentation with lower lip, classically it was hypophosphatemia rickets. Yes. Dr. Yetting's and Dr. Musa's case was earlier onset with hypocalcemia, going more in favor of BDTR. The third case was also earlier onset with significant failure to the suggesting of proximal RTA. Yes. And this is a slightly lower case with much more effect now, which is suggestive of weight of minus 8.9 SDS. Yes. It's a huge low in terms of growth. So this goes into distal RTA. So if you just look at the clinical parameters, you can make a diagnosis in most cases. Yes.
SMI was pre-pubertal at 12 years of age. So it suggests that a chronic process had been going on that was unaddressed in this child. Systemic examination was grossly normal. So in our database, we have a 12-year-old girl born of non-consanguineous conception with normal antenatal and perinatal periods, with failure to thrive, polyuria and pathological fractures. On examination, being wasted and stunted with acidotic breathing and features of rickets. So if we look at it, if we look at the three major things, failure to thrive, polyuria and features of rickets. We can think of chronic malnutrition, which can explain the failure to thrive and rickets. However, it cannot really explain the polyuria. Moreover, chronic malnutrition will be associated with other micronutrient deficiencies, with protein deficiency, but she had no features of hypoproteinemia. She had no features suggestive of any other micronutrient deficiency. Type 1 diabetes again can explain the failure to thrive and polyuria, but for a child 12 years old who has been symptomatic since about 6 to 8 years of age, not having landed up in DK so far, is less likely to be type 1.
So of course type 1 will be,
and it will not explain the rickets. DI again will not explain rickets in this stage. Conditions of fat malabsorption again won't be explained.
So can severe disease cause polyuria?
Yes, long-standing, yes.
Hypokalemia. So hypokalemia can cause nephrocytic. Yes, but celiac could be a theoretical possibility here. But if you look at the bone picture, it is too characteristically very severe in this case.
So the points that remain here, especially knowing that she had an acidotic pattern of breathing, are RTA and CKD. Now, as we've already seen the algorithm, the thing that will immediately help us distinguish between the two is the serum creatinine level. So let us have a look at his investigations. Okay, so in a child with rickets, if the child responds to the conventional therapy, we are looking at a deficiency rickets. If the child is not responsive to the conventional therapy, then one needs to look at the phosphorus levels. If the phosphorus is low, we look at the blood gas. In presence of acidosis, we're looking at RTA. If the blood gas is normal, look at the calcium and PTH levels, normal in hypophosphatemic rickets. And we've already seen. So again, the only thing I'm concerned about right now is the creatinine. So if the creatinine is high, I know I'm looking at CKD. If the creatinine is normal, I know I'm looking at RTA. If we look at the blood gas, a high in iron metabolic acidosis will tell us about, ketoacidosis, lactic acidosis, organic acidemia. But a normal in presence of normal anion gap metabolic acidosis, if the urine anion gap is positive, look at potassium. High potassium will suggest type 4 hyperkalemic RTA, and normal or low, in presence of normal or low potassium, look at urine pH. If it is low, then we're looking at proximal, and if it is high, we're looking at distal RTA. So these are the investigations of the index case at first presentation. So hemoglobin is normal. So definitely creatinine was normal, hemoglobin was normal. So this pretty much rules out CKD in this child. She had borderline low potassium level. Blood gas and anion gap showed normal anion gap metabolic acidosis. Urine routine was normal, so there was no glycosuria, no amino
And the
acids.
severity of acidosis was much more compared to what one only presented.
Yes.
So this is
Yes.
classically there.
Catch point here again is the urine pH of 5.8 with a high calcium, urine calcium creatinine ratio, and an ultrasound KUB showing nephrocalcinosis. X-ray risks which were widened on examination showed cupping, praying, and spleen.
And there was also some pathological factors also.
Yes.
Which
So, so looking at differentiating points between the different RTAs, we know that the primary defect in distal RTA is a defect in acidification of urine. So you cannot lose the proton in urine. Proximal RTA, whereas the defect is reabsorption, so you're losing a lot of bicarbonate in urine. These usually present with polyuria, polydipsia, and muscle weakness with failure to thrive. Catch point here again is nephrolithiasis or nephrocalcinosis, which will be seen in distal RTA. The urine pH will be higher compared to the other two variants. And serum bicarb, as you had seen in the index case, it was around 11, whereas in the proximal RTA case that we saw previously, the serum bicarb was around 16. So this brings us to the diagnosis of distal RTA in our index case. Looking at the treatment options, we see that the bicarb therapy advised here is 1 to 2 millimoles per kg per day, whereas in the proximal RTA, it is about 10 to 15 millimoles. So when you're losing bicarb, you will have to supplement more bicarb to correct the deficit and to supplement what is needed for the body. So our final diagnosis here is distal RTA in presence of normal and anion gap metabolic acidosis, borderline hypokalemia, and hypercalciuria with nephrocalcinosis. Treatment, the goals of treatment are to correct metabolic acidosis and to prevent nephrocalcinosis if it has not settled, and if it has, then to prevent it from progressing further to CKD. The management includes alkali therapy, hypercalciuria and hypokalemia resolved with adequate acidosis correction. Potassium needs to be supplemented, especially in the initial part, because as we know that these children will have hypokalemia despite metabolic acidosis. So they've lost their intracellular stores to maintain an ECF level. Thiazides may be required in children with persistent hypercalciuria to prevent progression of nephrocalcinosis. A newer therapy that is coming up is ADD 7103, which is a prolonged acting granular formulation of potassium citrate and potassium bicarbonate, which has found to be which requires only twice daily dosing as compared to the previous thrice daily dosing. It is found to have lesser GI side effect and therefore better compliance to therapy and a better metabolic profile in 2-year follow-up studies so far. Last but not the least, one must screen all children with distal RTA for SNHL, which is often irreversible and requires cochlear transplant. Again, another thing that I would like to highlight is because this was a near adolescent girl presenting with features of distal RTA, had it not been such a long duration thing, and if we had features suggestive of a rash or an SLE-like symptoms, one will have to look for features of secondary
Yeah,
This
that's
is
very
not
important because autoimmune association, we have cases of Sjogren's syndrome.
Yes.
So look for the eyes, look for the oral mucosa that becomes important, and ANA, of course, is required as a basal workup. But this looks more like a congenital one as form of the RTA. So I think this was again a wonderful presentation. So distal RTA, basically the problem is that you are not able to excrete the proton, and you are able to, or there is a back diffusion there. So what you need to do is that you need to give a lower dose of soda bicarbonate. And as you improve that, the intracellular acidosis improves, and because of which the potassium excretion goes down. So while your hypokalemia is there, it will actually improve with. Linda is asking that children with lower limb deformity have problem with their phosphorus, so that means phosphopenic rickets. You cannot generalize, Dr. Linda, like that. We expect that hypophosphatemic rickets will have a later onset and lower presentation. And this basically is that if you have predominant lower limb abnormalities, in this case, you have to worry about a possibility of phosphopenic rickets if there is no other problems. Dr. Sayan is asking any specific cause of dental abscesses in hypophosphatemic rickets. There are some local issues predominantly from the dental aspects, and people talk about this happening even without. And even with treatment with burosumab, they tend to continue. So it's not just a direct phosphorus related cause. There is some other issue which is working on that. So patients with burosumab may have improvement in rickets, but their dental problems may persist, which means that it's beyond phosphorus. There is some other effect of phosphatonin, which is playing a role, Dr. Sayan, there. Dr. Linda is asking, when does one test for 125 dihydroxylase? So calcitriol level, we should keep it only at a very late stage. If we look at our algorithm, we say you start off with phosphorus. If your phosphorus is low or normal, do a blood gas. If your blood gas is normal, do a calcium and PTH. If both are, if you have hypocalcemia with hyperparathyroidism, only in that case, you may do a calcitriol to identify difference between VDDR1 and 2. Dr. Tania is asking from Bangladesh, long-standing distal RTA present with generalized proximal tubular dysfunction. Yes, we have many cases, and that's because of secondary hyperparathyroidism. Your hyperparathyroidism will cause a Fanconi-like picture. So this, in fact, this case, or maybe a severe case like this, already had amino acid urea. So if you remember the chart I presented, 4 cases of distal RTA actually had amino acid urea. That is because of secondary hyperparathyroidism. So what I'm trying to say is that main aim is to look towards a diagnosis. Your diagnosis may not be established on the first day. Often you may have confusion, like we were treating him like VDDR2 initially, but he responded very well. So the main aim is for clinical improvement. So if you keep on thinking of diagnosis and don't give a proper treatment, there's no point. Similarly, proximal versus distal, the issue may be settled later on, but you have to give bicarbonate properly and then you assess from there. So yes, you can all go and have a look at our website, our courses which are available, and the mobile application. So